Thank you so much for having me and for giving me the opportunity to hear about the truly incredible work that Zero has already achieved and hopefully will continue to go on and achieve. Just like to acknowledge that I'm giving this talk on Gadigal land where I also work and live, and this is unceded Aboriginal land. I pay my respects to elders past, present and emerging, and also to any Aboriginal or Torres Strait Islander peoples here in the audience and virtually. Okay, so I was invited to speak at this symposium. At the moment, a lot of my work has been in the reproductive space, but I've also worked in cancer over the years. I was an investigator within the Pigeon Project, which coupled up with David Thomas's work at the Garvan. And I've also done some work on precision public health, the use of genomic information to augment existing stratification for cancer screening in populations. But a lot of my time in recent years has been taken up with the project that is summarised on the slide here, Mackenzie's mission. And not all of you may be familiar with this project. It is a research project that's actually just coming to its conclusion now. And it was a national project to provide a form of reproductive genetic carrier screening to any interested couple who could get access to the program through a range of specialists around Australia. And it is named after a little girl called Mackenzie who died when she was 7 months old, not from cancer, but from spinal muscular atrophy. And her parents asked, why didn't we know that we were carriers for this condition? And so after a period of lobbying and advocacy, including with long-term collaboration and activity from members of the genetics community, Greg Hunt funded a trial. And in that trial, screening has been undertaken for 1,300 genes to detect around 750 conditions. And an important aspect to qualify here is that we're not reporting all of those genes to individuals. Reporting is on a couples basis, so the detection rate is well under 5%. But what we wanted to do was to look in an interdisciplinary way to see how a program like this might be delivered at national scale in the future. So you might be thinking, why is she here? What on earth has what she's talking about here got to do with precision oncology, and particularly in a paediatric sense? Well, I think the synergies here are that this is a program that's just taken place at very large scale. So this is a program that has taken genomic techniques and delivered them to a lot of people in a very short amount of time, with a lot of curation and a lot of discussion and a lot of interdisciplinary collaboration. So, why compare these two things? So it is one of the first large-scale initiatives to offer screening to previously unaware populations. And there might be some synergies there with Zero, because the patient or participant journey in Mackenzie's has not necessarily been through a known family history of a genetic condition. Now, there are families participating in Mackenzie's that have a known family history, as I'm sure there are families in Zero too. And we have just finished testing over 9,000 couples of various family types. So you can come with a donor, doesn't matter if you're in a same-sex relationship or a heterosexual relationship, or a single person bringing a donor. And there was a very detailed discussion process around what genes to screen for, which I'll discuss in a tiny bit more detail. And also we saw firsthand a lot of the dilemmas that can come up in variant curation and reporting, and deciding what to tell people and why, knowing the really significant implications of what we were communicating. So what might be some similarities between a project like Mackenzie's mission and a project like Zero? So questions are going to arise in both of these settings about how to engage with end users and their families, what genes or variants we should be looking for in reporting. I should add, Mackenzie's used an exome approach, so maybe slightly different, but sometimes there will be variants that come up that we need to determine what to do with, and what to do or whether to look for other information in the data that is obtained, and I'll talk about that in a little bit more detail. And then also how we should do this at large scale. So there are around 300,000 babies born a year in Australia. So if this program is ever to be rolled out nationally, obviously it's an enormous program, But also the number of children presenting with cancer we heard earlier today is in its thousands as well. So, not necessarily the same scale, but both big in comparison to where, say, more traditional clinical genetics has gone. And then whether to reanalyse the information that is obtained, and if so, how and for what and when. How might the programs depart from each other? So I've already mentioned Mackenzie's mission reported information on a couples basis, and that was a trade-off between the size of the size of the numbers of genes that we were looking for, and also the representation of those in the population. The information in Mackenzie's mission was aimed at informing reproductive choice, whereas in Zero, obviously, it's looking at whether treatments are available and also to help explain why the cancer occurred in the first place. And gene selection in Mackenzie's is potentially broader because it involved things that could impact any bodily system, but obviously cancer itself is not a monolithic thing either. So we could be looking for cancers in every body system. And then Mackenzie's mission, arguably, I can come back to this in questions potentially if I have time, suited to be classified as a form of population screening. And so we spent a lot of time thinking about a single test offer to sort of have a more routine counselling protocol, for example, anything that could allow this to happen for a very large number of people per year and potentially accessible through primary care as opposed to through specialists. Now, that might not be the same for Zero. I don't know that any of you would classify this as a population health initiative, but it doesn't necessarily seem to be a more classic clinical test either, in the sense that it's going to be delivered in a whole lot of specialisms and potentially at a very large scale in the future. But that's just a few ways where these two programs might overlap and where they might depart from each other. But when I was talking with the organisers in advance of the conference, was just sort of throwing some ideas around about some of the things that are coming up in Zero and then some of the things that came up in Mackenzie's, and just some insights and reflections on what happened in that program and some of the points for consideration that come out as a result. So I'm going to just talk about 4 things in the remainder of my presentation. The first is just some very brief information or a reflection on ethical paradigms that we used in Mackenzie's mission and how they can complement and augment some of the more traditional thinking that we've tended to do in bioethics. Then thinking about what genes to look for and how to report those and the ethical implications therein. What we might do when we start thinking about returning potentially unrelated information. And that has come up in Mackenzie's mission, but at this stage, there has been no move to return information that is unrelated to the screening program itself. And then again, what to do in the future with this information, whether to reinterpret or reanalyse, and then whether and how to recontact. Again, at this point in time, Mackenzie's has not taken any steps in that direction. I think the program administrators and leads have been rather focused on actually getting the program delivered. But I am certain this question will come up in the future. So let's just have a brief reflection on ethical paradigms. So bioethics as a field or a discipline, we argue amongst ourselves as to what we are, has traditionally focused on the clinical encounter, medical ethics, a fairly narrow focus on a patient-doctor interaction and an emphasis therein on what is best for that individual in that context. This will be something all of you will intuitively understand and experience, whether through your practice or through your experience as a patient. And so you'll hear terms here like autonomy, paternalism, autonomy good, paternalism bad, best interests, let's try to promote those, particularly in children. We spend a lot of time thinking about what best interests of children might be. And we do things like respect confidentiality. We obtain informed consent. So this is all, of course, incredibly important and worth upholding. But when we start to think about really big-scale programmatic interventions, this alone can't give us everything that we need, because we need to start thinking about system-level problems. We need to start thinking about patients as a group as well as individuals. We need to think about how patients have their health determined by the socioeconomic context that they live in, their education level, their ethnicity, etc. So in Mackenzie's mission, we have also drawn a lot on public health ethics. And this has been a more recent entrant into the bioethics world, really only in the sort of last 10 to 15 years. And this takes a more collective and communal focus. It looks at interdependencies between us. It looks at the relationships that we have with each other and how these influence the decisions that we make. It thinks and talks a lot about equity of access, equity in health system planning, equity in designing a health intervention to fit well in healthcare systems. It talks a lot about public trust or patient trust in what is happening and what things they're being offered. And we talk about terms like solidarity and reciprocity. And solidarity really means standing beside those who are impacted by the decisions we make and imagining what it might be like for them and trying to design a service so that we stand for them, with them, and also, very importantly, as them. That is, we involve patients in the decisions that we make. And I've already mentioned we talk about relationships. So these two things together can inform really big, scaled-up interventions, such as Mackenzie's mission and Zero. So what we advocate for in Mackenzie's mission is to promote autonomy while also attending to many of the concepts that are prevalent in public health ethics. So it's not necessarily just one or the other. It is about shifting up from only the clinical interaction to also think about some of these bigger questions. How does what we do fit in the healthcare system as a whole? How should it fit? How can we ensure that we're delivering this service in a way that is equitable? How can we pay attention to the cultural and ethnic factors without stereotyping people, for example? And how can we think about all of the things that I've listed on the slide here, the barriers that people might experience in accessing services, the background inequalities that might impact whether they choose to engage in testing, and how we make sense of a decision perhaps to decline some information. And then also, how do we even offer this test in such a way that it can promote genuine reflection and choice? Because we are so primed to believe that information is valuable and that testing can only be a good thing. And sometimes, obviously, a lot of the time it's brilliant, but we also need to ensure that we're offering testing in a way that can promote that reflection. And also, what are the collective values that are going on here as well as the individual ones? So let's now think about what genes we choose to look at and what variants we choose to look at. So Mackenzie's mission had a committee that chose the genes, and I had the privilege of sitting on this committee. We didn't always agree, and we didn't always get it right either. We have changed the gene list over the course of the project. And part of the difficulty here is there's no rule book for how to choose genes to report at this type of population scale. So we looked at things like the prevalence, what views were from members of the public and patients. We looked at the concept of severity, which I'll come back to in a moment. We looked at questions of actionability, or what you can do with the information that you obtain, how easy it is to find this information, and how confident we can be when we're calling a variant. And we wanted, as much as possible, particularly because this was information to influence reproductive decisions, a very important decision was made to try and avoid reporting VUS in that context. But it is really important to regularly revise what it is that we are looking for. And I would say almost all of that is true for a program like Zero as well. And so this will be not new information to any of you, and I'm absolutely certain you know more about it than I do. But things that we paid attention to in Mackenzie's were variable penetrance and variable expressivity. Just sort of noting that, you know, while you could see the molecular information almost with 100% certainty, what that then translated to as information that had to be parlayed in a meaningful way was sometimes not so certain. And also we were acutely aware, as I'm sure you all are, that we have a lot of work to do to get population databases up to speed with respect to ethnic diversity, and there's a lot of awesome work happening in Australia in that space now. But we needed to be really careful that the information we were giving to people was something that could actually meaningfully influence the choices that were then going on to be made. But also, there was a lot of concern about missing something. And, you know, clearly we have a lot of anxiety around going through this whole process and then someone ending up developing a condition that we could have seen but didn't because of our processes. And So this is a really difficult balancing act between picking up what we really should be seeing, but also trying not to pick up things that actually won't help the individuals that we're seeking to serve. And we don't want to overdiagnose individuals or put them back into the healthcare system to have testing resources expended on them that actually didn't need to be done in the first place. And this is part of this thing around just trying to get that balance right between being overcautious and being perhaps too enthusiastic, and thinking about that in the context of the health system as a whole. And the other thing we spent a lot of time thinking about and also writing about is the concept of severity. And I think this is particularly relevant in a reproductive context, but is perhaps relevant for a program like 02. So there is no definition of severity or seriousness in the literature, and there is a lot of ongoing debate. And it is an essentially contested concept because there is so much subjective information that is relevant here too. Does it have to be life-limiting? Does there need to be an intervention? What is the burden of this condition? And how do we conceptualize a concept like suffering in relation to this as well? And so what we also need to think about is, well, how do we even talk about severity? Who do we ask about this? And there's been a trend in the literature more recently to sort of say, well, actually, what we've tended to do in the past is talk to doctors. We haven't talked enough to patients. We haven't distinguished things like the concept of health from the concept of well-being. And what we do when we speak to patients is that we find that people perceive they have a really great quality of life, even though objectively they might be living with relatively poor health. And so it is important to start bringing those additional voices to the table as well when we're starting to think about what we might be looking for. Okay, so another issue that has been prevalent in programs like Mackenzie's, and I would think 0 as well going forward, is what to do with, in the future potentially, returning information that goes beyond the scope of the original test or screen. And this is obviously possible to do because of the high throughput mechanism that we're using to obtain the information, and the fact that most of this data is being stored for obvious reasons that we can then go on and do further research and sharing across national and international borders. And so what we can ask here is, well, what are the implications of this? Is this appropriate to return information to people, whether now or in the future, that goes beyond the stated aims of the program? And some might say, well, this is just obvious. This is a complete no-brainer. The information is there, so why don't we use it in a way that can further benefit our study participants or our patients, depending on the context? Why shouldn't we curate and report this information? And in something like precision oncology, this could include looking at the ACMG list or returning carrier status in the future, or thinking about VUS, for example. That's just some examples. And the other thing we know is that generally when we ask people about this, they say, yeah, sure, I'd love that information. Thanks very much. And so what we want to do here is just to say, okay, let's just stop and take a second here. Let's go back to the discussion around clinical ethics and public health ethics. Think about the way that we're conceptualizing ideas such as autonomy. Are we thinking about this purely as more information equals more autonomy? Or are we thinking about this as how can this information be meaningfully used in the context of a health system as a whole? Are we looking purely at this as an individual patient-clinician dyad when actually we should be thinking about it more broadly? And so we need to look at this in context with the health system impact as well. So one thing you'll see for me when I give presentations is that I'm not a yes-no bioethics scholar. I'm a, here's the messy stuff in the middle, let's try and unpick it all. And I think this is an instance of that. This is a complex question, and our job as, well, my job as with my colleagues as a bioethics academic is to help us flesh out and decomplexify some of this middle ground and give us some points for consideration. So some of the points in this context are things like, we know that population databases, as I've mentioned, remain not as great as they could or should be at this point in time, but getting better every day. We also know that there are ongoing limitations in the population around genomic literacy, and people may not always have an opportunity to really carefully think about what this information might mean for them. And we also know yet health systems probably aren't quite ready to have large-scale interpretation and feeding back into the health system. But this is coming. It's all coming. Ness, I can't remember your saying. What did you say this morning? You're learning fast or something? Yeah. Learning faster together. So these are examples where we can learn faster together. And, you know, we think about the impact on healthcare systems, and going back to that tension between not missing anything and not finding too much, and how we can navigate that carefully. And we just also need to consider the counselling considerations pre and post provision of information that goes beyond the scope of the original test. And then something that's starting to come out a little bit and also overlaps with the next thing I'm going to say around reinterpretation is that sequencing technologies are improving all the time. And so I've heard, you know, we often hear that genomic data is static. We capture it, we store it, it's there. And then we hear people say, well, hang on, no, genomic data is not static. Genomic data actually, a sequence that we can do 2 years from today will be way better than a sequence that we did 3 years ago, for example. So it might be the case that actually the reinterpretation debate also needs to depend on the quality of the sequence information. So, reinterpretation. So the point here is to plan for it. And I'm sure you know that already, and I'm sure you're all probably quietly panicking about what this might mean for the future. As yet, there is no so-called duty to reinterpret. There is varying debate about it globally, and along the lines generally around, I guess, the approach to incidental and secondary findings. The debate is drawn along similar lines. Some are calling for a universal duty to reinterpret data, but the clear barriers at the moment are resourcing and knowledge, in the sense that we can't look for something that we don't know exists yet, and also we can't go back and look for things if we don't have the resourcing in laboratories to do so. And so some of the arguments in favour for doing this are that, you know, this knowledge is dynamic, but the data, subject to the thing I said just before, is relatively static and it's already there. So the data, the interpretation at the time a sample was first analysed is not necessarily always going to be true. And we have a climate of rapidly changing patient expectations in this space too. People obviously are keen for knowledge and keen to get an answer to why their child developed cancer. And we also want to avoid harm. If we know in the future that a result we gave a family is no longer the correct interpretation of the data, then obviously there's a significant desire to go back and to correct that with the families involved. And that's just as true in Mackenzie's mission. And on 1 or 2 occasions in Mackenzie's mission, they have actually gone back because they learned serendipitously that a result was no longer an accurate interpretation. So the points for consideration here are that, you know, genomics is kind of almost an exceptional thing here, because I can't, off the top of my head at least, think of another clinical example where the thing is retained, but the knowledge moves on. So if I have a blood test, you know, that analyte is chucked away, I get to keep my images, my radiographer doesn't keep those necessarily, and they're not going back to them routinely 5 years after the fact to look with new knowledge, because the resolution of those tests was as it was at the time it was done, and the point for interpreting is kind of lost. So, you know, how do we derive an obligation here from the progress of knowledge? It's a really interesting question to unpick. And if we're looking at reanalysis, should we wait for database representation to catch up, or actually should we be doing it already with the data that is the best across multiple ethnic groups? And a related point is, well, actually, should we be looking at populations that have been traditionally underserved? And should we be doing reanalysis in those groups first, because they're the ones that are maybe more likely to have received an inaccurate result in the past? There was just a really great paper in New England Journal of Medicine that demonstrated that Black and minority ethnic groups in the US have tended to receive less accurate results in the past. But also maybe rare disease is another example where reanalysis might be maybe prioritised. And so they're just some points that I think are really important to take on board. So if we are going to think about reinterpretation, reanalysis, recontact seriously, let's plan for it now. In the interim, a more tightly curated list might sort of make this problem go away a tiny bit, but also at the same time then the trade-off is that you're not finding as many things. And so obviously in a program like Zero, you are really focused on going down all those rabbit holes and finding that really granular information and combining it with RNA analysis and all of the other wonderful things that we've heard about. But I think two big questions are, whose responsibility is reanalysis? And is it actually even appropriate to say I'm going to pin it on the laboratory scientists, or I'm going to pin it on the clinicians? That it doesn't seem a reasonable thing to say to me. And then also, who should fund it and how? And obviously we know health funding in Australia is a really complex beast. I think we need to be thinking now about how we plan to reanalyze in the future. Okay, so just to conclude, the insights from Mackenzie's mission and how they can help us think about big-scale programs like Zero. I would say we consider ideas from both clinical and public health ethics, and obviously I've presented those in a slightly dichotomous way, but they are obviously overlapping as well. Let's think about looking for information that can be sustainably tested and interpreted at scale, perhaps including by non-experts as mainstreaming goes on, and which reflects broad input from clinicians, patients, other advocates, in the sense that we need to understand how lots of people feel about the information that's being obtained. Let's be led by the likely value that information will have, obviously for cancer care in the first instance, and then potentially other things going forward, with reflection on that the third part of my presentation. And we need to think about information provision cautiously, but not necessarily ruling it out entirely. And we need to plan now for reanalysis and recontact, and thinking about that both in terms of the potential obligation, but also the potential avoidance of harm in the future. Just like to acknowledge funding from Mackenzie's mission, but also Dr. Lisa Dive and Dr. Gabrielle Watts, with whom I've done quite a lot of this work and thinking. Thank you. And if you're interested in the publications from Mackenzie's mission that have to do with ethics, if you scan that QR code, you can see a list. Thank you.
So we do have time for a couple of questions, if there are any. Yes, at the back.
Is this on?
You're on
yes,
now.
Hello,
Anya.
it's Anya Ravine. That was great. Ainsley, thanks. Look, I'm strongly against the notion of genetic exceptionalism. I just like to put it out there. Is there something unique about this? Actually, I don't think so. And the two scenarios that come to mind immediately are, say, CT, MRI scans, huge data, and they're interpreted at some point in time, and then we know more, and it could be reinterpreted in the future. And same with, say, histology slides. Diagnoses keep shifting as time goes by, so I don't think it's really all that different conceptually. But so I guess the one thing that is perhaps worth thinking through is inheritance, and this information is relevant for others in the family. Now, that needs thinking through. Anyway, yes.
Don't let go of the microphone, because I'm going to ask you a question back.
Good.
Thank you, Anya. Your comments are always so thoughtful. And I think, totally take your point around those other two counterexamples, which I couldn't think of yesterday when I was putting that slide together. And I think you're right. I do also, it's kind of my job to try and be a tiny bit exceptionalist, because it's how I've managed to eke out a career in this space. But at the same time, it's interesting. I think we kind of inherently exceptionalise, and then also inherently realise that we're probably not exceptional, and it's kind of a tightrope that we walk every day. But the question I have for you, I guess, is particularly because the potential for inheritance, and with your role as a genetic pathologist or a laboratory person, how does that make you feel intuitively about this so-called or potential duty to reanalyse? If there are, implications for family, then would that not make the sort of impetus for saying that we need to be doing this stronger?
Yeah, look, it's a really good question, and linked in with it is the whole conversation around data retention.
Absolutely.
And ability to reanalyse. And certainly there are some eye-wateringly worrying scenarios out there of wrong result was issued, and then years later it surfaces as an enormous issue. So it's really got to be thought through carefully. Data retention, I think that we need to have a real conversation about the pros and cons of that, and if you're retaining it, for how long?
Yeah.
Yes, I should stop.
Great, thank you.
Can I ask, sorry, Richard Mitchell, Kids Cancer Centre, thank you very much. Very interesting, very thought-provoking talk. I would say in your start of your presentation, you're like, oh, this hasn't got to do with, this has everything to do with everything, right? And in fact, when we think about how we are moving forward, one of our responsibilities with Zero as a program is about how can we translate this science to as many different fields as possible. And because for so many reasons, including sustainability, right? Both your programs, our programs, we have to figure out how do we make this sustainable? How do we make it fundable? And when governments look at that, they're going to look at things like, well, how many people can you touch? Like how much impact can it have? And so it is about collaboration. I mean, we're in paediatric oncology. That's what we've done our whole careers. It's about collaboration. It's how we've gotten better. So can I ask you the bioethics hat on, how do we tackle that when we're talking about, collaboration of data, working together with different programs? Say that we teamed up with Mackenzie's mission and said, okay, well, this is the genomic data we've got for both of those programs. And then we go to the renal guys and say, hey, they're looking at something too. We have all that together. How do we tackle that bioethically?
I'm going to sort of cheat my way out of this question a tiny bit to say it's a really huge question, and I'm not going to be able to answer it all today, but actually we've just been funded by the MRFF to come up with a governance framework for genomic data in Australia, and that project's just getting going now and will run over the next 5 years. And so if anyone is interested, please drop me a line, because I happen to be the lucky duck who's leading that project with 44 extremely other talented people. And so the first year we're going to be basically mapping the landscape and looking for pain points. And so ideas around collaboration and demonstration of value, I think, will be really key. A point that I think might have been implicit in what you were saying, which is slightly separate to the data question, I think, is we're not yet fantastic at capturing what we mean by the value of this type of testing, whether it be just financial but also the psychosocial and ethical value. And the systems that we have for funding are set up to not ask the right questions, I think. It's really challenging to convince MSAC of the value of this type of information, or activity-based funding, for example. So I think we need to come up with better ways of articulating and measuring the value of these types of interventions, because we all know that they're awesome, but it's quite challenging. I think I'm going to get kicked off the stage in a minute, but
I think we might leave it there. I apologise.
I'll find you at lunchtime, Kathy.
Ainsley will be very popular.
Another one over here as well to find at lunchtime.
Yeah, so
yeah,
please
thank
find
you.
Ainsley at lunchtime. Please join in thanking Ainsley again.